Good morning.
Good morning.
We have known Chris for over 4 years now. From the beginning, he has shown compassion and a confidence for success. Our son Gray has been victorious in 2 fights with neuroblastoma. So we're thankful for the research for the Damon Runyon Foundation. Chris is a dedicated physician and scientist. So it's our pleasure to introduce our doctor and our friend, Dr. Chris Bosse.
Kristopher.
Thank you to the Green family. I met Gray my first year of fellowship, and we've been fighting this disease together for the last 4 years. And as you can see, he looks great and is doing great. So we're very, very, very happy. I think what they don't know is, it's a huge pleasure and really honor to work with these families and really fight this disease. So it's as much of a pleasure for us to take care of them as it is for to really help them get rid of this really devastating malignancy. So as Shay mentioned, I'm a physician-scientist at the Children's Hospital of Philadelphia. And I'm a pediatric oncologist. In the laboratory, I study this disease, neuroblastoma. So neuroblastoma is a disease of the developing peripheral nervous system. It's the most common cancer in young children and infants. And it's a very heterogeneous disease. And the children who are classified as having high-risk neuroblastoma really continue to have very significant morbidity and mortality from this disease, and that's what Gray was diagnosed with, high-risk neuroblastoma. And so you can see on the, I guess your left, there's an MRI of a cross-section of a child's abdomen, and I think you can appreciate the big mass on the left, which is a tumor coming from the adrenal gland. And then on the right is a MIBG scan, which is essentially a neuroblastoma-specific PET scan. And all the white dots you see are sites of neuroblastoma. So these two, this is from another child I treated at CHOP, but this is very common to see in children who present with high-risk neuroblastoma, really diffuse disease with large abdominal tumors. So this is a survival curve for neuroblastoma as a whole. And as I mentioned, neuroblastoma is a very heterogeneous disease. There are some kids who have localized tumors or tumors with a different biology that do quite well with either surgery or a little bit of chemotherapy, all in the outpatient setting. But there are children like Gray who are diagnosed with high-risk disease, either based on their age, their tumor stage, or specific tumor genomics that, despite all those therapies I listed there, which is really every single type of anti-cancer therapy we have in our arsenal, that takes about 2 years to go through, and it's pretty much all inpatient therapy. Despite all that therapy, we still are only able to cure about 50% of the kids that we diagnose with this disease. So I think clearly there's much work to be done. And the other piece of this that I think is just quite striking is even for those kids we're able to cure, they are almost always left with life-altering morbidities that are really lifelong. And here's just a cartoon of some of those treatment-related side effects that kids who go through this therapy have to deal with. And there's things such as endocrine deficiency, such as growth hormone deficiency and short stature, thyroid problems, heart damage, lung function problems, infertility. And then there are rarely kids develop secondary cancers that are usually leukemia. So clearly, I think we have to get better not only at how effective our treatments are, but that we have to make them much safer. So I think as you heard from both Dr. Kalin and Melody, a way we can do that is to utilize the host immune system to both potently and safely target tumors, and especially pediatric solid tumors. So there's been a lot of research done in treating leukemias with things like CAR T cells or other immunotherapeutics, but what remains a major challenge is to move those therapies to solid tumors, especially pediatric solid tumors. And one of the major challenges to doing that is to really identify those tumor-specific cell surface proteins that you can target with these with these therapies that are only found on tumors, aren't found on normal tissues, that we can safely target with these potent therapies. So we, in my laboratory, asked this question for neuroblastoma a few years ago and really compared a large cohort of neuroblastomas to normal tissues. And you can imagine, so what we're looking for is these shapes, these different colored shapes on the tumor that are tumor-specific cell surface molecules that are found on tumors but aren't on normal tissues to really allow us to safely administer these potent therapies. You heard about CD19 in leukemias. It's essentially the perfect immunotherapeutic antigen. It's only found on B cells, which are replaceable with IVIG. In the solid tumor world, those antigens don't really exist, or at least we don't know of them yet. But what we found in neuroblastoma, there's a molecule called glypican-2, GPC2 I'll refer to as, and it actually ends up being very differentially expressed on most neuroblastomas, and actually now what we know is other pediatric cancers and adult cancers, but really with very limited expression on normal tissues, including pediatric normal tissues. So we thought this was a wonderful tumor-specific antigen to target with immune-based therapies. So in truth, we're developing a number of different immunotherapies towards this molecule GPC2, and I won't talk about CAR T cells today, but I think what has really been one of the most promising new drugs we've developed in my lab is this thing called an antibody-drug conjugate. So very simply, an antibody-drug conjugate is an antibody which binds specifically to different proteins in the body, and what we do is conjugate it with different drugs. And these drugs are very potent drugs that aren't safe to administer by themselves and really only are safe to administer when they're conjugated with antibodies to really allow safe and targeted therapy just to those tissues or tumors that have this cell surface protein. So we've built one of these for GPC2, and again, just to drive this point home, if GPC2 is this green triangle, you can see it's only on tumors, not on normal tissues, and you can imagine if we administer this antibody-drug conjugate, it only binds to tumor tissues and really leaves those normal tissues alone, which is not the case with really any other of the cancer therapies we give. They're relatively nonspecific and do damage normal tissues. And then you can imagine there's a child who has a tumor, and again, we administer this antibody-drug conjugate, and it just gets specifically to the tumor, but leaves the normal pediatric tissues alone. So not only is it a very effective drug, but it's very safe because there's no off-tumor side effects. So this is, and I apologize for the chemistry here, but this is the new drug we made for targeting this molecule GPC2 in neuroblastoma. We identified a specific antibody that just binds this protein and then linked it with this very potent drug, this PBD dimer, which essentially damages DNA and then the cells go on to die. And essentially this will only be taken up by neuroblastoma cells or other tumor cells that express this molecule, and it doesn't get taken up by the normal tissues that don't have this molecule. And so this is an example of, actually, this was the first mouse experiment we did with this drug, and I'll walk you through this. So on the y-axis is the size of the tumor in the mouse. These are all human neuroblastomas in immunocompromised mice. And on the x-axis is just time. The ADC antibody-drug conjugate was given just once at time 0, and you can see on the gray and the black curves are the controls that didn't get drug, and all the other curves are at the baseline. So essentially what we saw was a very rapid tumor regression that was sustained up to 5 months, and then the study was ended. And these numbers are hard, I think, to appreciate, but so I drew some relative tumor volumes. So the controls at about 3 weeks into the study were that size, and the drug-treated tumors were the smaller circle. So this is not something we typically see with any drugs that we study first in our preclinical model, so we're very excited about this. We've gone on to expand this to other neuroblastoma models, actually other tumor models that express this antigen, and we see similar effects. So we're currently in discussion with many industry collaborators to try to now take the next step and move this into phase 1 clinical trials. And I'll just end by saying, although I'm a neuroblastoma doctor and physician, we are very interested in moving our therapies really across pediatric cancers and adult cancer. So what I want to show you here is that this molecule, GPC2, is essentially expressed on at high levels in other pediatric cancers in the blue and in the gray, so even some adult cancers. So for instance, retinoblastoma, which is an eye tumor of children, it's expressed on 100% of those tumors. Most neuroblastomas, medulloblastoma, which is a pediatric brain tumor, it's expressed on a large percent of those. Wilms tumor, which is a kidney tumor of children, leukemias, and even this really devastating brain tumor, GBM, which is glioblastoma multiforme, both adults and pediatrics. So what we hope to do is really expand this and other GPC2 targeted therapies to across these other malignancies. And I'll just end by saying, I think you heard a lot about the Physician-Scientist program. I'm now at the end of my second year of funding, and it's just been really instrumental in sort of bridging my fellowship now to, I'll stay on at Penn as a tenure track assistant professor. So I think the funding from this program has really been instrumental in my career development, my lab, growing my lab, developing the research, a little bit of which I've shown you here. So I'm immensely grateful, and I thank all of you for really continuing to fund this program. So thank you very much.